listening to Community Health Watch on WNHHLP 103.5 FM, New Haven's home for community radio. Insightful conversations, impactful ideas, and voices shaping our community and beyond. Let's begin the dialogue.
Good morning. I'm Leroy Odinga Perry, Cultural Ambassador for YCCI. And with us today, we have our co-host, Reverend Alvin Clayton. You want to tell us what you do, Reverend?
Good morning, everyone. I'm Elvin Clayton. I'm the pastor of the Walters Memorial AME Zion Church in the Park City, Bridgeport, Connecticut. I've been a cultural ambassador for some 15 years, and we're just happy that you're joining us today.
All right. And our guest today is Dr. Isaac Kim, a phenomenal physician, researcher, oncologist, urologist. He's everything. We're going to ask him just to tell us a little about himself and how he came to be part of the Yale School of Medicine.
Good morning, Reverend Perry and Reverend Clayton. It's such an honor and privilege for me to have this opportunity to speak to you this morning. And again, I think, to your question about how I came to Yale, I was born in South Korea to a father who's a pastor, God-fearing, who's a Methodist pastor. And my mom was also, I think, even more God-fearing, I think, than my father in a lot of ways. So you know how that goes with the mom and dad. So I grew up in South Korea and moved to the States when I was at the age of 11. And early on in my years, I remember my mom saying that I had two choices as a career. One, either I'm going to be a pastor, just like my grandfather was also a pastor. So she wanted a third generation pastor. So I was going to be either a pastor or a doctor. Either way, she said, I'm going to be helping men or humans spiritually or physically. And you know what choice I made sitting here today, speaking to you. But anyway, so I came to the States at age 11 and gone on to medical school and did all my trainings. Early on, I understood that the prostate cancer was a disease that was affecting majority of the American men, or many of the American men felt that this was cancer that I wanted to devote my career to. So once that decision was made, then I went on to do a training in robotic surgery. The idea being that this was new emerging technology, and my impression was that this was going to be a game changer early on in my career as I perceived at the time. This was back in late 1990s. So once my training was done, my first faculty appointment was at Rutgers Cancer Institute, New Jersey. And again, life kind of takes a serendipitous turns. And I grew up in California. I went to school in the Midwest and wasn't all planning on going back to California. But my mentor, who again guided my career when I was at Baylor College of Medicine for my residency training, Dr. Ronald Morton, actually brought me to New Jersey. Again, never thought about that, me ending up in New Jersey. But I had a great time there and learning a lot, and as well as, again, helping a lot of patients in New Jersey at the Rutgers Cancer New Jersey for about 16 years. And then the opportunity came up at Yale about 4 years ago. And again, this was I think a son of an immigrant family, a pastor, having the opportunity to lead the department at Yale. It's like a once in a lifetime type of opportunity. So I took the opportunity, came here, and haven't regretted it ever since. I've had a great time meeting everyone and running the department here at Yale.
Awesome. Let me just get a shout out to our station manager, Harry, and WNHH 103.5 in New Haven. They've been one of our sponsors as we're making this journey of bringing to the doorsteps of those in the community knowledge about new research and innovations in medicine. Dr. Kim, you had mentioned once that the Yale Urology Department, you had wanted to somehow make it a destination urology program. Can you tell us how the fruition of this vision has worked out?
Sure. So this is still a moving this is still a vision, still in progress. We're still to achieve this goal. And I think prostate cancer is probably pretty close to it, or if not, we're already there. Basically the idea is this, Yale is a world-renowned institution where, again, everyone just about across the globe will just recognize the name. It's just got such a prestige and just the recognition that's associated with it. So that has been done, I think, across the board. But I think in terms of the clinical operations or our clinical expertise, I think we have been too modest in not telling the world of who we are, what we're able to do. I think we do a very, very good job. And in fact, I think if you look at some of the numbers and mortality numbers and how our patients do, that I think Yale, again, School of Medicine has a lot to offer, and I think we do quite well. I think so. It's more of my vision of when I came as a chair of the department. It's just letting the rest of the world know how good we are clinically here. Also, I think again we just have not been, I think, good at tooting our own horns. And to that end, it has been my goal as a leader to go out there and to let the world know that we have a very good doctors, physicians, surgeons within our department who's able to provide the best care for all patients with urologic disease. And I think prostate cancer is one of these areas that we have made some headways now. We have patients coming from all corners of the United States, as well as some international patients coming in now. Based on, again, our surgical expertise, our outcomes, as well as some of the innovative clinical trials we're running now. So we're beginning to make some difference, I think, in terms of, again, attracting patients from outside, because, again, I think Yale has a lot to offer, and I think we just have been too modest in not showing our results to the rest of the world.
Dr. Kim, I was told some years ago that that almost all men at some point, if they lived long enough, would get prostate cancer, which was kind of scary to me. What I didn't know at the time was that African American men died disproportionately to their counterparts. And so, the technology, I think, from early on that has frightened many of us, because we have some of our colleagues in the early 90s who had surgery, did not have robotic surgery, and in many times they suffered because of the sleight of hand, or because the technology wasn't there, or because maybe the doctor wasn't really as sharp. Or so I applaud you on this robotic surgery. We were with Dr. Lerner at one point in our ambassador program, and then when he showed us a video of him being across the hall and doing surgery in another room, and he was saying how precise it was and how much cleaner it was and sharper. It was truly amazing to us that this technology was out there and that our community knew very little about it. I appreciate the fact that you have taken upon yourself to come into the community, and that is laudable. I mean, there's not many doctors who will come out to community centers or to conferences to talk about this disparity. You want to tell us a little more about that? We want our audience to know that you were at the James Gatlin Community Center in Waterbury with the Omegas and the Masons, and then the reception that you got after that. It was amazing to me to see young guys who I thought would never submit to thinking even about getting tested for prostate cancer, but they were on you like bees to honey. Can you tell us about that experience?
Yes, again, again, let me just, I think, start with some of the basic statistics. I did, again, I think the 2025, there's actually a publication that comes out every year called the Cancer Statistics. And this is basically what to expect or what the past numbers were for on an annual basis. So 2025 number just came out. I took a look at it. And I think there's some good news as well as, again, bad news specifically with respect to prostate cancer in the Black community. So overall, the incidence of prostate cancer still remains much higher in the Black community, with the overall rate being somewhere around 1.6 times higher for a Black man versus a white man. And unfortunately, again, if you're diagnosed with prostate cancer, that if you're a Black man, that you're more likely to die from the disease still at this point in time, with the overall likelihood of dying from prostate cancer around 2.1 times higher for a Black man compared to white man. So even with the prostate cancer being diagnosed at this point in time, that if you're a Black man again, somehow they just don't do as well overall with respect to survival. That being said, if you look at the 5-year overall survival rates between the two races, between white and blacks, I think actually that gap has closed. So I think in the near term, again, prostate cancer is a disease that we need to follow decades for us to know exactly what overall impact we've had. But it's certainly in the near term, the latest number statistics, the 5-year overall survival rate for a Black man is 97% versus 98% for white men. So again, I think that gap is pretty much narrow or pretty closed. So I think again, I think I'm remain hopeful that I think this number will translate into I think improvement overall. Certainly we have to follow the numbers much longer for us to know. So I think and I think there's a snippet of data that shows I think a good and the good news and the bad news for the Black man there. So, one of my goals in doing trying to get out to the community is a prostate cancer is disproportionately hitting the Black man or affecting the Black man. And I've been following this particular fact and trying to address this for over a decade of my career now. And then what I do is that I think there's limitations in what I can do with the surgical expertise, my surgical expertise, my knowledge that I have. That's just going to allow the access to data that I would have. But I think again, that information is useless unless I get out to the community and let the patients know that these are what's possible, what are numbers out there, awareness, et cetera. Early on, again, I think it's actually not fast. I really enjoy getting out there because I think there's, first one part is to educate the community, let them know, but also get to learn a lot about where the community is in terms of advocating for itself. And I have to say that, compared to more than a decade ago when I first started this and getting out to the Black community when I was in New Jersey with one of my patients named Ralph Stowe, who helped develop start the organization called the Jazz for Prostate Cancer. So we started with that journey and then coming to Yale and continue to get out to the community on a regular basis. That what I've noticed again is that there's a palpable difference in terms of being aware and I think advocacy for the Black men in getting out and prostate cancer screening, getting treated appropriately in time. So I've seen I think a significant swing in terms of the advocacy coming from the community. So I think the community has been very good at or has rapidly learned, as well as again, I think it's knowledge based in terms of the prostate cancer, how it's affecting the community disproportionately. I think it is out there now. So, that's one part. I think the part that I'm still trying to get out there is I think then how do you go from now educating the community to empowering the community, right? Really at the end is you want to make sure that these knowledge that, pointing out that, hey, there's a difference here. There's a difference in terms of how the prostate cancer outcome is. But ultimately, me as a doctor, I want to see that knowledge in empowering, in telling to the communities that's then turns into a gain in which the men and the Black men with prostate cancer will do just as well as white men. And I think that comes from, I think, empowering the community. So I think that is the next step in my goal, my personal goal, in getting out there. So again, you and I discussed about some of the approaches that I am considering or contemplating or proposing, right? But again, I think that is the next hard step now. Is that now, we've done the relatively easy part, educating. So now then, what do you do about this? But again, that is the ultimate reason why I go out to the community and continue to engage, because again, I think this is topic. I mean, if you talk about a outcome or death from a prostate cancer or any disease, that's 2 times higher in one community. I mean, we got to do something about this to close this gap.
But Dr. Kim, let me just say this. Going back to what you said about the survival rate, that the gap is closing, the only reason that statistic exists is because we were able to treat African American men. I think the problem is that getting them into treatment so that they can be a part of this hopeful long survival rate that will equal that of their counterparts. And I think that is the real problem. And I know that you had, one of the questions we asked, what can community do? What can the school, the university, what can our legislators do? And our community groups. And I think that one of the suggestions you made had to do with how do you impact this with like legislatures here in Connecticut, like you said, if you could meet the governor, I believe, you might be able to give him the statistics to show the understanding that there exists and still exists this disparity. And we want to get that word out to the governor. So we want you to give us the pitch now so that we can push this with our people in the House here in Connecticut.
Yeah. I mean, again, thank you so much for giving this the opportunity to talk to the governor. I don't know if he's listening, but nevertheless, I mean, this is reality, right? The prostate cancer incidence in the state of Connecticut, we're ninth in the nation. The 50 jurisdictions, plus Puerto Rico, and we're ninth in the nation. So prostate cancer does hurt our state disproportionately, relatively speaking. I think best way, not best way, but certainly in trying to address or close this gap of prostate cancer disparity, that multi-pronged approach has to be in place. And one of that, I think government does have a significant role in, I think, pushing and trying to close this prostate cancer disparity gap. First of all, I think this has to become a priority. I mean, I took a look at when I came to the state, to move to Yale, and took a look at the research portfolios or the research support coming from the state in terms of cancer research and trying to close or improve cancer outcomes. Prostate cancer is not even on the list. I mean, that, again, in New Jersey, where I came from, certainly was very different. So I think it speaks again at the end, right? I mean, we can always, I think this is something that, Reverend Perry and we talked about is that talk is cheap. Right, at the end, we have to be able to put resources behind this if we're really going to be serious about closing this gap. And I think that is where the serious leadership has to come, it has to step in, I think, from our state leaders in doing this. Because at the end, yes, we go back to this, Reverend Perry and Reverend Clayton and the rest of the community, we talk about closing the prostate cancer disparity gap, right? But at the end, it's going to take resources. It's going to take money. And as a community, right, and as on an individual level, we just don't have that much resources to be able to pour in or allocate to closing this prostate cancer, again, disparity in the Black community. I think that's where the role of the government comes in. And you and I talked about this. I'm pretty passionate about somehow the states offering, as well as the federal government level offering prostate cancer screening for Black men. Now, I've been, again, there has been a lot of controversies about prostate cancer screening. But at minimum, I believe that this is going to be necessary for that Black community to have access to, in terms, I think, again, closing the prostate cancer disparity gap. So to that end, again, I think if you're going to offer prostate cancer screening to all Black men at no cost, again, the government sponsoring and supporting this, resources are going to have to go in. I think that has to come again at a broader, bigger scale, because again, I think on an individual level, it's just been hard to do this. And I'm glad to say that one of my recent colleagues who joined Yale, William O, who was previously the head of Prostate Cancer Foundation, for the first time, I saw his group put out a publication actually stating explicitly that Black men should be screened for prostate cancer, that this should be done. So again, I think, as the community, also the professional communities are coming around this idea now. So, but at the end, again, the resources limited, and this, I think the allocation or dedication of resources into the prostate cancer screening, I think, has to come at some level, either from the state government or from the federal government. And to that end, again, the Reverend Perry, you and I talked. I think, if I get an avenue to go and talk to visit our leaders at Connecticut, at Hartford, certainly I'll be happy to go up there. It'll be my honor and privilege to be able to advocate for the communities. And these are the reasons why we have to do it, why I think this is going to make a difference in terms of the prostate cancer disparity gap between the Black and the white Americans.
Dr. Kim, let me just say that, we're a little late with after this election. We are a little late, but we're not giving up. Cleveland Clinic was doing a study of Black men with heart problems, and they put this study out because they saw how it affected disproportionately Black men. And so they were doing the study, and then someone said, "Oh no, that's affirmative action. You're picking out certain groups of people, and you can't do that." And they closed that study down. We want to hope that America is going to be greater than that. And our hope is that there will be those out there who are listening to the cry of those who are hopeless, those who have been marginalized, and those who suffer the most.
Yeah.
So our team, our cultural ambassador team, and all of our friends, and with this show moving forward, we're going to try to push to see if we can't do something on a larger scale to address this issue.
Yeah. No, again, Reverend Perry, and I agree in that sense, but also I share some optimism because I think at the end, right? I mean, with the professionals like myself partnering with the community, right, and advocating. I think I think the great thing about American democracy is that ultimately at the end, right, the power comes from the people, and we advocate for ourselves and our people, and our patients, and our friends, and our family members. I think that our leaders are obligated to listen. I think that's what makes our country great. So I feel optimistic in that sense. Yes, you know what, there will be ebbs and flows in terms of how the politics work. But from my end, I'm not going to change anything. I'm going to continue to advocate, and I'm going to continue to work on it and try to understand from a science the understanding, trying to get more knowledge in behind it, as well as again advocating on a social level. Because again, I think that's how we make difference in our country.
You can't.
Dr. Kim,
parents.
Dr. Kim, I need to just ask a question that's burning. Is there a genetic link that might contribute to the increased risk, or that could help us better understand and treat prostate cancer?
Yes, so it's clearly there are, but I want to actually go back. So actually, I'll take, so I do want to caution about the genetics, for a reason, because ultimately it comes on, if you're saying that there's a biological differences in terms of the black men and white men, right? I mean, I think I think it has a lot of, implication that we have to be careful of. But that being said, let's first answer your question directly. Is that yes, there are genetic links or there are genetic changes that is associated with prostate cancer, because at the end, cancer is just a changes in genetic makeup, and that's what result. Majority of cancers, that's where the abnormal growth of cells occur, right? So one of the example most recently in prostate cancer is so-called the DNA damage response pathways. All right, so these are again how cells respond when the DNA gets damaged. And we understand that some of these pathways are altered in prostate cancer, and we can actually exploit this in terms of treating prostate cancer. There are other genetic links that have been proposed, I think, but again, the data is pretty thin in terms of whether they are really linked to prostate cancer or not. But I want to go back to, I think, this whole issue of genetics and prostate cancer, because the reality is this, early on, when you and I met earlier and discussed about how I got interested in prostate cancer. I was of that camp that I think there may be some sort of something biologically inherent to Black men that makes them much more prone to getting prostate cancer, dying from prostate cancer, right? But the reality is this, I've just pursued this topic, and I think I came full circle around. And what I realized, I think, with our most recent paper is that if you adjust for all the issues, all the social issues that we have in prostate cancer in terms of our cancer treatments outside, the reality is that that disparity gap between the white men and Black men closes, it goes away. So like it or not, yes, biology, genetics makes difference, but ultimately at the end, in terms of, I think, the major players, right, in trying to close this gap has to be societal issues, socioeconomic issues. I think, again, I'm of the firm belief that if we offer equal screening and equal access for Black men for prostate cancer, I think we can close the disparity gap between the two races.
Thank you. We've been telling men that early detection is important. Would you just share that in your words to help the brothers and sisters understand the importance of getting tested early?
Absolutely, right? So again, if prostate cancer is no different than any other cancer, in that, when it is caught early, that's when the surgery or radiation is really, really effective in curing of the disease. When the cancer has escaped the primary disease site and traveled to the lymph nodes or to the bones, when it becomes incurable. So it's of paramount importance that if patients have prostate cancer, you detect it early so that it can be treated and can be cured. I think the difficult part is that then how do you pick up prostate cancer early? And I think this is where the screening comes in. And I really echo the sentiment of my colleague William O. In advocating that all Black men should be screened prostate cancer. The reality again is that when patients are looking for symptoms, with respect to prostate cancer. Okay, you know what? I'm having such urinating issues. I got to go see the doctor now. And if prostate cancer is causing those symptoms, it is too late by then. So when you're waiting for cancer, prostate cancer, or when you're waiting for looking for certain symptoms and go look for a doctor, that is usually too late. So really, if you want to catch prostate cancer early in its form where it's curable, then you have to see the doctor before you develop any symptoms from the prostate cancer. So that is again where I'm advocating that there should be a regular checkup for all patients all men who are at risk for prostate cancer. And I think to that end, again, I believe, again, this is something that I've personally advocated based on the data is that all Black men should get their PSA or blood test done, the initial screen for prostate cancer at age 40. And again, I think based on the number, you can certainly curtail as to or increase determine how intense that follow-up should be. But at minimum, their initial screening should be there in somewhere around age 40.
Thank you.
Dr. Kim, there is the PSA, but there's also the digital exam. And back in the day, that was one of the things I think that discouraged some Black men from getting screening. And nowadays you hardly ever see physicians even using that method. Is there a reason why? Is it the digital not really working or it doesn't work?
I mean, I think PSA is very accurate in detecting prostate cancer, but it is not a perfect test. And yes, I have noticed also that, even educating our medical students, right, that they don't get as good at, I think, training in terms of doing the digital rectal exam. This is how you use your finger to palpate the prostate and assess, right? So there has been some advocacy and whether a digital rectal exam does add any value to detecting or screening for prostate cancer, because reality is that it's an invasive exam. Again, a lot of most men don't like it. I mean, I've had it done. I'm at that age also, and it's not pleasant, right? It's not pleasant, right? I think, but nevertheless, again, I do think that there's a value to do it. So I certainly do it, perform it in all my patients coming in to see me. But the pendulum certainly has swung in that sense. I think it's also, I think it's just most combination of societal factors, plus I think also doctors not being well trained in carrying out the exam. But I do believe that based on my personal experience, that somewhere around, again, not minuscule, right? Somewhere around the patients who have the normal PSAs, or patients who have normal PSAs, you come in and do a rectal exam. That I've kind of picked up in a handful of patients over my career. Now it's a lot of patients, but nevertheless, again, that's has added value to it. The other thing also is it's a powerful. Let's see, I mean, that's a part of the staging decision, right? I mean, in terms of assessing, how the surgery should be done, whether I should do a wide resections or, again, how aggressive surgery should be, the rectal exam adds value to it. So I think it's something that we should do, but nevertheless, again, it certainly is not done by many doctors at this point in time. Oh,
Dr. Kim.
Yeah.
Right?
Yes. Can you tell us about the SimCap clinical trial?
Oh, yes.
Go right ahead.
Sure. So it's a topic that, again, I'm very, very passionate about. This again, SimCap stands for Surgery in Men with the Carcinoma of the Prostate. So that's a SIMCAP. And this is actually a study in patients who have metastatic prostate cancer, right? So these are patients with prostate cancer that's gone to the lymph nodes or distant lymph nodes. That's just outside the pelvis, up into your chest, up into your belly. Also cancers in the liver, or prostate cancer in the bones, prostate cancer in the lungs, etc. So these are patients who have quote unquote non-localized prostate cancer. And for these patients, currently the standard of care is that the medical treatment, like hormonal therapies, chemotherapy, is the standard of care. Some studies have shown that radiation may be effective, but that has been questioned, I think, with the latest data. So really, there is no role proven role for local treatment in patients with metastatic prostate cancer. Because the idea is this, right? If cancer is already spread beyond your the primary home, it's gone to outside your where it came from to other part of your body, that any sort of local therapy hitting its home, what's the point of it? Because especially for prostate cancer, if you do that, you're going to have a significant impact in terms of quality of life of the patient, right? Because being able to pee on your own, being able to urinate on your own is something very, very important. That's very private, but something that's, again, important for quality of life. So whenever we treat locally for prostate cancer, you have the potential to impact the urination habit of that individual, and thereby again impacting the quality of life of that patient, right? So in the years past, we thought that for these men, that when they have these metastatic prostate cancers, that local treatment has no role. Now, it's a long story, but I've come to the conclusion that that may not be the case. That if you actually remove prostate cancer or the primary prostate disease in men with metastatic prostate cancer, again, this is disease that's gone outside of prostate, that I think these patients will do better. Again, I think the analogy I make is to this. Again, I take the movie analogy of the Independence Day. I love that movie because Will Smith is one of my favorite actors. I love his the movie that he produced or is part of. And I think if you see that movie, what you see is that you see like an armada of UFOs invading Earth, right? And they're like all over the globe, San Francisco, DC, etc. And Will Smith and everyone else is trying to, attack this UFO, so they can't until Will Smith, gets up to the mothership behind Moon, right, and then destroys it. And then now the missiles and everything else, it starts penetrating the armor of the UFOs that's on Earth, right? That's the idea. That I think if the mothership, prostate cancer or prostate disease, primary disease, if you take that out, then I think the missiles, which are the hormonal therapies, the chemotherapies, now become more effective in hitting and getting rid of cancers in the bones, livers, lymph nodes, etc. So that's the idea behind it. Certainly, it's not a proven concept. That's why this is a clinical trial. The trial is now near the end of the initial phase. We were to accrue 190 patients for the trial, and this morning we have 182 on the study. So we just have 8 more patients to accrue, and then we'll see again what the initial readout would be. I'm very optimistic. I think this trial should it's going to show something in terms of, again, the role of the surgery in patients with metastatic prostate cancer. But again, I caution that it is not a proven concept. That the study, if someone wishes to join, it's a study that's going to be randomized. So there's a 50-50 chance that individual, that patient may not get randomized to surgery, that the standard of care, because that's the only we'll know, right? The science is that we have to compare the current standard of care with a new intervention and see if there's any difference in terms of the outcomes.
Thank you.
Can you explain that again? I mean, the procedure. So is it a surgery or is it so after the prostate has been removed, there's another surgery to get rid of cancer that may have spread?
No. So these are for men who present with metastatic disease up front. So right now, about 310,000, 300,000, a little more than 300,000 men are estimated to be diagnosed with prostate cancer in our country this year. And of that percentage, about 7% will present with a metastatic disease, right? So these are patients, again, on presentation already. So these are patients who have not had an early screening or routine screening. They just wait until the symptoms develop, right? They start coming to doctors. And for those men, they would have cancers already in the bones or in the lymph nodes. And right now, the current standard of care for these patients is systemic treatment, like chemotherapy and hormonal treatment, and not surgery or radiation.
Wow. Because I was a little confused at first, because I thought that if you were to do just the surgery, then I know that sometimes when people do surgery, it does spread even after.
That is correct. So the reality is, I think, even with, surgery or radiation, again, I want to keep putting it in there. Radiation is an option for men with localized prostate cancer that with all the science that we have right now, ultimately, I think about 30% still progress after 5 years. So progression is the blood test, so-called the PSA, we call it biochemical recurrence. So yes, the current science is still not perfect. We still, I think, again, why does the recurrence occur? Well, one of the primary reasons is the problem that some of the cancer cells have already escaped prior to that intervention. So all the staging workups that we have are not accurate enough to accurately predict which patients the disease have already traveled outside the prostate or not. So, again, with the current technology, we think that, hey, disease is still limited to the prostate, but the reality is about 30% will still progress. I think the other portion of it is likely inadequately treated local disease. Again, it's difficult to say which is what, but certainly if you have a inadequate radiation, let's say, to the prostate, or inadequate, or surgery was done in such a way that some of the cancer cells have been left behind. So that's another possibility for having the prostate cancer recur after the local treatment.
Is radiation and hormonal treatment normally given together?
So the studies have shown that if you give radiation plus hormonal therapy, that is effective. But that data is to patients who have either high risk disease or intermediate risk disease. So someone who's got a low risk disease that you probably don't need it. I think that's becoming like it's using basically a missile, right, to go after. It's a small thing, right? This, I think, it's being too aggressive. But yes, that combination is certainly the most effective. Radiation plus hormonal therapy is the most effective in terms of treating localized prostate cancer. But again, I think, whenever you give additional treatment, there's always potentially going to be cost to the patient. So you have to use it judiciously and try to assess what the risk is and what the benefit is to the patient. And that is why I think having a careful consultation with a radiation oncologist or doctor is necessary to decide if the hormonal therapy should be done with the radiation therapy or not.
We were told that not all, that we were told yesterday, talking to one of our future guests on the show, that the shoe doesn't always fit all feet. You have to look at the individual to see where they are before you can't just lump everybody together and say this will work for you. So if you got an 80-year-old man or a 40-year-old man or a 20-year-old man, the treatment might be different, but you really need to get an expert to help delineate what is the best treatment. And I think I think we've had this discussion too, that not every doctor is equal. I mean, they have MD behind their name, but they don't all graduate first or second in their class, as long as they graduate. And I think you had mentioned one time that the statistics of those who do well against those who don't do as well may have something to do with who's doing the treating.
Yeah. So I think this goes to the whole idea of how American, the difficulty, I think, for our average patient in navigating the American healthcare, U.S. healthcare system, right? I mean, if talk about, I think, from a more of a business perspective or consumption perspective, I've seen a number, again, I cannot recall the particular publication, but it said that I think the American healthcare is probably the most expensive item that patients buy without knowing what you're buying. Right. I mean, you're going in and seeing, and you think that the doctor's got an MD after it, he has some years of training, that you think that, again, you're going to get the best care. But the reality is not. The medicine's still an art in a lot of ways. Doctors have do different things. So again, I think to that end, I think I think that point is underscored by the fact that if you look at the standard of care for, let's say, something comes out, a new drug comes out for prostate cancer, and that drug is shown to be effective. On the implementation part, where that drug gets adopted at the end, it's roughly around 25 to 30% if you look at the data right now, right? So the reality is that we have great science and everything has worked, and hey, this is the latest thing that's going to be helping the patient. But doctors are not the same in terms of using this, adopting these new standards and doing this, right? So I think this is where the educating the community, educating patients is going to be very, very important. What I stress when my patients come into my clinic or in my office is this: I consider shared decision making, because at the end, right, what is important to me as a doctor may not be so important to you, to that individual. For me, what is important? Well, I want to be able to get my patients off the table, after surgery is done. I want to get them out of the hospital healthy, quickly, et cetera, do okay. But for the patient, you know what? I mean, sometimes that may not be their ultimate goal, right? Is it their goal may be that, hey, you know what? They want to minimize the time down because they have some sort of priority. Let's say someone's, wedding or some really, really important family decision they have to make, et cetera, right? So for me, you have a cancer in front of you. Hey, then getting treated is the most important decision. But that is from my perspective, right? Who's am I to say that, hey, that is, the right way to think? Everyone, again, we all have different priorities and different competing issues and what's important to us. So to that, again, I try to educate, work with my patients and let them know what the issues are. And at the end, empower them to make the right decision or the decision that is most appropriate for the patient as well as the family. I think that then I think, going back to the whole idea then about, finding the appropriate doctors who's able to deliver this information to the patient, right? And then be able to, again, guide them in making the decision process. Yes, I think that the patients, I think, have to be much more cognizant, aware of such effects in variability in terms of the outcomes amongst the physicians. And I think this is where I think the Black community has to be more aggressive in educating about this. I think these variabilities and actually advocating that the patients are seen by the best doctors.
So we need someone like you to point us in the direction.
I'll be happy to help, but again, I think there's going to take more than me. But this again by getting out there. I think ultimately at the end, it'll go back to it, empowering, right? I mean, I think there's going to have to be some trusted sources of information that can be developed that the patients could look to. I think that could only come from within the community. But again, certainly I'll be honored. It will privilege of mine to be able to work with you and Reverend Clayton and the rest of the community leaders. I think to develop something like that.
Doctor, in the studies that you're having now, have they become more diverse than in the past?
Unfortunately not. I think this is where I think when I get out to the community, especially coming from Yale, coming here and then going out to the community with you, and the rest of the culture ambassadors, I'm so happy to see that because I think that's where the next difference is going to have to be made, right? Is that now I begin whenever I go out to the community, I think the prostate cancer awareness is certainly out there, and that the fact that you need to be again screened early. I think the Black community has embraced that. But I think what is now the next step in terms of really moving the science forward, and as well as a lot and helping more Black men, is going to be, I think, participating in clinical trials. The reality is that in our trial, again, this is a multi-institution, multinational trial. But at the end, Black men comprise less than 5% of the trial, right? I mean, if you look at the prostate cancer incidence, they should make at least 20%, and yet, we get less than 5%. But this is not just unique to our clinical trials, right? This is something that is faced just about all clinical trials within prostate cancer space. And again, right, you have a disease that disproportionately hits the Black community, and yet you have a very, very low representation of the Black men in these clinical trials. So these scientific decisions or scientific conclusions are made based upon largely Caucasian men or white men and their outcome. So how can you then assume that number is going to be relevant or it's going to be pertinent, or it's going to be same for the Black man? And I draw the point about I think the immunotherapy. Again, this is not a proven concept, but it shows that something very alarming in a lot of ways. There is the only proven prostate cancer specific immunotherapy is called Cipulocel-T or Provenge. And when this was approved, this was first thought that, hey, this is going to help men with metastatic prostate cancer live a little longer. When it came out, again, a lot of promises. But at the end, it didn't turn out to have a huge impact in terms of outcomes. It's also very, very costly. So it has not been used a lot. But Dr. Oliver Sartor has recently took a look at this data and went back and looked at the original cohort. And they found out that if you're a Black man, that you responded better, looked like. Certainly, again, it's very, very different, right? But the reality, again, is that we just don't have enough Black men to be able to come to a firm conclusion that, hey, you know what, immunotherapy may be more effective for Black men. So I think something like this, again, tells, I think, a lot about the potential impact by having the appropriate representation in clinical trials. So I do, again, that's something I am advocating hard for is yes, there's a lot of uncertainties. I do acknowledge that, right? Because at the end, when you participate in clinical trials, there's going to be a potential cost that we just don't know about and may not benefit you right away. But I do think there's something to be said about, again, participating because the study results are going to come out. that's going to be again having, I think, huge implications, potentially huge implications for the community. The other thing also I advocate though is that at the end, right, I go back to the whole original point about maybe 25% to 30% of men get their standard of care with prostate cancer for the new drug treatments. So by participating in these clinical trials, that actually you do get the standard of care. Right. So you're more likely that 25% now because everyone involved in the care is making sure that you're getting the standard of care. So I think there's a potential benefit for all men participating in clinical trials anyways.
You know, I just want to give a shout out again to WNHH Community Radio, because we're bringing this right to the heart of our New Haven community and to our partners here in the New Haven area and the greater New Haven area. And Dr. Kim, I want to ask you, you know, you mentioned something that I think is important for people to note, and that is, you know, people think that, you know, when they go into the hospital, they're going to come out with a large bill, that there's going to be money coming out of their pocket. They're already going to be missing work perhaps and other things. And we believe that the cost is minimized by the fact of what the treatment might bring. You know, it's like that's how it is. But I think that might be a reason too, that people just do not have access to the study or information about the study. You know, it's like we don't know how you would get in the study other than a doctor recommends you to this particular trial. So is that the only way that an individual would know about this trial?
Yeah, unfortunately, we really haven't found, I think, a great way to directly reach out to the patients. So it has to be when the patients come in to see the doctor, having that provider be aware of the studies that we're running, because that's the reality right now. But that being said, again, you know, again, I love again going out to the community, right? I'm talking to again, you know, talking about the clinical trials directly to the patient for that reason. I want to empower them and let them know what trials are running. But at this point in time, again, there's really no formal venue for patients to go and be able to say, okay, you know, these are the clinical trials that's there, and I'm eligible for X, Y, Z. But again, you know, as I've, you know, so that, you know, see it in your mind, you know, before in your head before, right? That, hey, I want to be able to empower the community. So I think this is something that I would love to work with you, right, on Reverend Perry, and the rest of the community leaders on developing a trusted source website where, and again, I envision this, right? I see envision a website that is advocated, that's supported by the Black community, and say this is trusted source, and you go in there, and then you talk about, you know, again, prostate cancers, you know, with the right patients, doctors with great outcomes. You can talk about clinical trials, you know, for different stages. This is where it is, you know, what should be done, things like that. And I would love to see, you know, that way of, I think, again, empowering the community. But again, this will be, I think, has to come as a partnership between the healthcare providers and the community.
How many clinical trials are you running now?
So I am the principal investigator of two clinical trials right now. Again, one is on patients with a high-risk prostate cancer. You know, as a surgeon, my academic interest or scientific interest is in surgical role in patients with high risk and the metastatic prostate cancer. So in addition to the SimCap trial, you know, I am running a clinical trial in which patients who have high-risk prostate cancer, that is there a way for me to do a more thoughtful, nerve-sparing approach for these patients? So let me go back and try to explain to what this really means. You know? So one of the fear or the side effects of a prostate cancer surgery or for radiation treatment is that patient will have a severe erectile dysfunction after the treatment, right? I mean, in addition to urination habits, sexual dysfunction is a huge concern for men. So in patients who have high-risk disease, so this is, again, prostate cancer that's more likely to spread outside the body. So that also means that its probability, its likelihood of involving tissues around the prostate, outside the prostate, is that much higher. Well, what are the tissues that's arise outside the prostate? These are the neurovascular bundle, so-called. So these are nerves that's responsible for erectile functions. So in short, in men who have high-risk prostate cancer, the probability or likelihood of the nerves that's responsive for the erectile function being involved with cancer is high. So in these patients, again, if they were to have an operation done, we have to do something called a wide resection. So I have to go out and take all the tissues in addition to the prostate, but tissues outside the prostate to minimize the risk of leaving any cancer behind after the operation. But then collateral damage from that would be erectile dysfunction, or significant erectile dysfunction afterwards. So the point of this trial is that if I can give patients some drug to shrink the cancer, downstage the cancer, we call it, then can I then get away, or can the patient do okay with a nerve sparing approach where the patient will actually be able to preserve the erectile function? So this is again, I got this idea kind of like, a woman with a breast cancer. In the old days, 30 years ago, let's say, when women has been diagnosed with breast cancer, you would do a radical mastectomy. That was what everyone thought. But then since then, we realized, that is not the case. I think if you have patients who have who are reasonable candidates, then you can do so-called the lumpectomy, which is preserving most of the breast architecture and then giving radiation treatments. So things like that is what we're saying here, advocating is that in patients who are appropriately selected, if you give him treatment up front, we call the neoadjuvant treatment up front, then can you downstage the prostate cancer so the patient will be actually then able to have a surgery that would actually preserve the erectile functions. So again, this is a study that is again, we don't know the complete results yet. We just I think finished just accruing the patients, so we're looking at our data right now, and hopefully we'll be able to have some sort of readout over the next 6 months, 8 months with this trial. But I'm really excited about this concept because again, I think a lot of thought went behind this in trying to again improve the outcomes of men again who are undergoing surgery.
I think that is phenomenal, and I think that is why we have this program so people can learn about this. I've heard of giving treatment like a pre-treatment that will help, so that when you got to the point where you had to do the surgery, that you'd already set the stage for success. And I mean, I think that I've read The Emperor of All Maladies, and so I kind of understand how the new science really is just so phenomenal, and our people just don't know about it. And hopefully shows like this can help us to determine. And one of the other things I wanted to mention was one of the innovative approaches that you had suggested to us at one time that we thought we might be able to do with the Masons and the Divine Nine and the Black men in the community, which was a take-home PSA kit. Or as they're doing in Charlotte now, they set up in a church. They brought the test right into the church and did the test and gave a meal. And that was one of the ways of letting people participate in something that would be instrumental in saving lives.
Yeah, so I mean, this is the concept that we're testing right now. Again, I think as you go this, I think this whole part about our goal and your and my collective goal has been to empower educate the community. But I think I think my impression is that we're getting there. I think the message is getting out there now. The next is how to empower them, how to give them more control of the process. And to that end, this is one of the ideas that was actually proposed by a medical student to me, right? Is that, hey, what about this home PSA testing? So I think the reality is it's not the FDA approved in terms of actually using these numbers, right? So there are some barriers with that, but it's like no different than, let's say, a COVID testing, right? When the COVID was there, right? That before going to doctor's office, and there's a lot of reasons why you didn't want to go in, right? That you given patients to say, take this if you feel like you need to. And then based on that result, then you can pursue the healthcare. So again, it's just our attempt to give more power to empower the patients so they will be able to, again, be more comfortable. I think there is to be something to be said about being able to just test on your own at home. I think, again, the question, again, is that how do you do this in a way, again, that is cost effective, allow the community, again, to be able to adopt this and be comfortable with this whole idea. So again, it's an early developing of our concept. Certainly we have not even implemented testing this yet, but again, plan is underway to assess and whether this approach is going to be impactful or will be helpful to the community or not.
I think that's awesome. I was going to ask Clayton that we give closing remarks because we're leaving.
Closing.
I was going to focus right on you right about now. And also mention again WNHH Community Radio.
our time is about up. And Dr. we thank you so much for your collaboration with our community and with our cultural ambassadors. Perhaps you can share your information with us. And until the next time, peace.
Thank you so much, Dr. Kim. We really appreciate it. It's been enlightening for all of us. And I wish we had more time because, you know, Dr. Liebman told us once that in China, there was some drug that helped shrink the prostate without any surgery. And he gave us the name. I wrote it down, and on the paper I wrote it down on, I lost. But I've been looking for that paper for years now.
You know, I'll talk to Dr. Lee, but I think there's a lot of drug that's been shown to shrink prostate cancer. But again, you know, if it really hasn't, if it's been years and it hasn't come out in the literature into the clinical trials, then you would have to suspect it. Maybe there's something that we're not quite sure yet. So hold off on that. But I'll talk to Dr. Lehman and find out for you.
All right.
Again, this has been a tremendous honor and privilege for me to be able to come before you, Reverend Perry, Reverend Clayton, and the rest of the community leaders for this opportunity. And, you know, I can go hours, maybe days talking about prostate cancer. So, you know how to reach me.
All right. Thank you so much. And we're out. Thanks again.
Thank you. Have a great day.
You're listening to the Community Health Watch Show on WNHHLP 103.5 FM, your home for community radio. Stay informed, stay connected, and take charge of your health. We'll see you again next time right here on the Community Health Watch Show.